A patient age 35 comes to your office with a forearm discomfort, complains that this is fatigue-like pain and there is numbness in the hand. She denies any symptoms at night and confirms that she works long hours on a computer. The condition has gradually worsened. When you examine the patient, there is some paresthesias or hyperesthesias around the thumb, index finger, long finger, and the radial half of the ring finger. There is pain on flexion of the long finger at the proximal interphalangeal joint. Sensory symptoms are also present over the thinner eminence and distribution. Patient experiences pain on palpation of the median nerve at the proximal forearm. And in addition, interestingly, pronator teres muscle itself is tender and firm or enlarged. Fill-in test is negative. The differential diagnosis here can be carpal tunnel syndrome, compartment syndrome, or pronator syndrome. The proximal symptomatology shows that it might be a pronator syndrome. When you do electrodiagnostic studies in such situation, they are not diagnostic mostly. Although the nerve velocity would be slowed down at the level of forearm, but it does not always show a carpal tunnel syndrome. The Simon-Winston monofilament and assessment may reveal decreased sensibility over the distribution of median nerve. EMGs may be useful if fibrillation, positive sharp phase, or reduced interference patterns are noted in Pronator quadratus or FPL. It is important to note that EMG does not differentiate median nerve lesions at the pronator teres from those more proximal. In this case scenario, the diagnosis is pronator syndrome. It's defined as a functional problem of the median nerve due to some mechanical abnormality at the level of forearm. This disturbance in function is often related to the path of the nerve through the middle of the pronator teres muscle. The clear physical examination is the best indicator for diagnosis of pronator syndrome, which is similar to carpal tunnel, but less common. Both syndromes involve median nerve and therefore have similar symptoms. The syndrome is usually differentiated by physical examination. Key to physical examination is note the area of tenderness is present and the presence of positive tunnel sign. It is possible that both conditions can coexist with median nerve entrapment in the proximal forearm and in the wrist as well. Correlating physical examination along with EMGs aid in diagnosis. No motor symptoms or weaknesses present with the pronator syndrome. Most of these patients are managed conservatively, but in our situation, we went on for operative intervention in this patient, as conservative management failed. The initial incision is usually within 5 cm proximal to the elbow crease, unless either a supracandidatal process or a accessory bicipital epineuritis is present. The incision begins no less than 10 cm proximal to the crease in our situation. The incision was curved distally, just medial to the bicep tendon. It zigzagged across the antecubital crease and curved back medially for 5 cm in the proximal forearm. The next step was to identify medial antebrachial cutaneous nerve and isolate it as continuous along with basilic vein. The median nerve was identified and isolated in a similar fashion. If a supracandidatal process or accessory bicipital epineuritis has been identified postoperatively, the median nerve is identified and isolated in the most proximal portion of the incision and then traced distally. The supracondylite process or accessory bicipital epineuritis is often dealt if present. It is important to explore the median nerve completely, as other more proximal sites of compression may exist in the same time. The median nerve is then dissected distally. The basipital epinosis is incised and the nerve followed to the proximal end of the superficial or humeral head of the pronator. Retraction of the head is often needed to identify any variations in the nerve path in relation to the two pronator heads. Any fibrous bands within the pronator should be identified and incised. In case where the median artery penetrates the median nerve, interfacial dissection may be useful to enlarge the passage. Greater care should be taken to avoid or ligate the artery, as the dominant blood supply to the median nerve in 30% of the times. Next, the superficialis arcade is explored. The arch should be incised, especially if thickened, and it may be source of compression. The surgeon should carefully dissect the distal to the arch, paying attention to the possible presence of anatomic variations. The tourniquet should be deflated, hemostasis should be secured, and bipolar cautery should be used as needed. The pronator is reattached if detachment is necessary. When reattaching the pronator, careful attention should be paid as not to shorten and therefore tighten the attachment. This could itself cause a new compression lesion. Epineurotomy, internal neurolysis, or subcutaneous transposition of the median nerve are not necessary most of the times. The subcutaneous layer is closed with a 4-0. Absorbable sutures and the skin edges are approximated with simple sutures. The extremity is placed in a bulky dressing with a reinforced above elbow dressing. Elbow should be positioned in such a way that to maintain 9 degrees of flexion at the elbow joint, 45 degrees of pronation in the forearm, and slight flexion in the wrist to keep the nerve in position of minimal tension. At day 10, post-op steps should be removed. Immobilization of the long arm cast in the same position is continued for additional 2 weeks, and then this immobilization is discontinued. Regarding the alternative method, the pronator syndromes can often be treated using protection. Long arm splints can be used in a position of comfort. Rest, ice, compression, elevation, medication, and modalities as well. Protection also consists of modifying activities to allow proper healing and prevention of further injury. It is important to explain to the patient in conservative management that it does not mean cessation of activity. By modifying activities, what we mean is not to exacerbate the previous injury. Medications like NSAIDs and corticosteroids, although very rarely utilized. Modalities like ultrasound, electrical stimulation, friction massage are not quite effective. While operative intervention have few surgical complications, the medial antebrachial cutaneous nerve is always at the risk at exposure. The entire course of the median nerve is explored to inspect all possibilities of site of compression, and scar may develop hypertrophy or will be unsightly at occasions.